Hello, I'm David Wolinsky from Cleveland Clinic, Florida, chair of the American Society of Nuclear Cardiology Appropriate Use Criteria Steering Committee. And I'm here on behalf of Refer Wisely to discuss evaluation of the intermediate risk female with chest pain. So we're dealing with a 63-year-old black female non-smoker with a family history of coronary artery disease. She's hypertensive on medications with a blood pressure of 120/80. She had a previous treadmill stress test that was non-ischemic. This was done as part of a syncope evaluation. Her electrocardiogram shows T-wave inversion in V2 and V3 with minor ST sagging. Her lipid profile shows a total cholesterol of 216 with an LDL of 138 and an HDL of 55. So based on the data presented, what is her 10-year ASCVD risk? And in order to calculate this, we go to the Global Risk Assessment Calculator based on the 2013 ACC/AHA guideline on the assessment of cardiovascular risk. You enter the sex, the age, the race, the total cholesterol, the HDL, the systolic blood pressure, whether or not the patient's on medications for hypertension, whether or not they're diabetic, and when they are a smoker or not. And based on the above, we come up with, for this patient, a 10-year estimated risk of 7.4%. Based on this assessment, now, she would be categorized still as low risk. However, the patient is still concerned because of her positive family history of coronary disease. She wants to know if her cholesterol needs treatment, and she wants to know if any other cardiovascular testing is needed. Let's look now at the algorithms for assessing patients on the need to treat blood cholesterol or do further testing based on the global risk assessment. As you can see here on the middle panel, she is between 5% and 7.5% in the yellow bar of 10-year ASCVD risk. Looking farther below in the yellow box, you can see that patient-clinician discussion is important and possibly further testing be carried out to further assess her. These options would include coronary calcium score, C-reactive protein, or ankle brachial index. In this particular case, it was decided to refer the patient for a coronary calcium score. Coronary calcium score is a measure of plaque within the coronary artery and looks at plaque burden. It is not a stress test and is not a reflection nor a measurement of severely obstructive coronary artery disease. Her coronary calcium score was 102.3. Based on these findings, does this change her short-term risk? Does this change her short-term treatment? And does she need further testing? So her short-term risk is increased based on the coronary calcium score from the baseline we established previously. Does this change her short-term treatment requirements? Yes, it does. Based on the above, with an increased risk, she would need to undergo treatment with statins and possibly with aspirin. But does she need further testing to look for coronary insufficiency or ischemia? And the answer to that is no. We can further elucidate some of these questions based on the next slide, which comes from Chang's group in Texas, which looks at the relationship between coronary artery calcium scores and the prevalence of abnormal myocardial perfusion scan and the prevalence of high-risk abnormal myocardial perfusion scan. As you can see in the horizontal axis, the coronary calcium score is listed, and the vertical axis demonstrates the number of patients involved. Yellow boxes indicate the overall incidence of abnormal myocardial perfusion scans, whereas the orange and red boxes demonstrate the prevalence of high-risk or markedly abnormal myocardial perfusion scan based on either a total perfusion defect score of greater than 15% or an ischemic perfusion defect score of greater than 10%. And as you can see here, that when patients have a score of greater than 400, there is a significant prevalence of abnormal myocardial perfusion scan, 31%. There are 10% of patients who have a total perfusion defect greater than 15%, and 8.9% of patients who have an ischemic perfusion defect of greater than 10%. However, looking in our patients category of a score of greater than 100, you can see only 10% of patients have abnormal myocardial perfusion scan, and a much smaller number of patients have markedly abnormal perfusion scan defined by total perfusion defect or ischemic perfusion defect. Therefore, based on this, the patient does not require further cardiac testing, but merely needs to undergo aggressive optimal medical therapy. 1 year later, the patient represents with new symptoms. She complains of episodic brief shortness of breath and chest tightness. Occurs when walking, and it makes her uncomfortable. Sometimes she gets dizzy when she exercises, but she says her exercise tolerance overall is unchanged. She drinks plenty of fluids when she exercises, but she's bothered by the fact that the symptoms are becoming slowly progressive. How should she be evaluated at this point in time? In 2013, the American College of Cardiology, the American Heart Association, and multiple subspecialty societies, including the American Society of Nuclear Cardiology, published the 2013 Multimodality Appropriate Use Criterion for the detection and risk assessment of stable ischemic heart disease. As you can see here on the next slide, this table demonstrates a variety of clinical scenarios based on previous testing results and symptoms, and options on which tests may be carried out based on their level of appropriateness. A represents appropriate, M represents may be appropriate, and R represents rarely appropriate. It should be noted that all tests considered appropriate, or A, have equal weight and can be ordered based on clinician and patient preference and local expertise. After discussion, the patient decided that she wanted to undergo coronary CTA. She chose CTA because she felt the radiation risk was lower. However, the CTA demonstrated intermediate findings. There was a 30 to 50% lesion in the proximal left anterior descending artery and a 30 to 60% lesion in the right coronary artery. This was felt to be inadequate to rule out obstructive coronary artery disease as the cause of her symptoms. Now, as I stated, the patient chose coronary CTA as her procedure of choice because she was concerned about radiation exposure with myocardial perfusion imaging. However, as you can see on the table on the right, new technology has allowed us to carry out myocardial perfusion scan with a markedly reduced radiation dose. Patients who are referred for SPECT imaging can undergo stress-only or stress-first imaging, and if they are normal, no further testing is done. This can be achieved with an effective dose of 3 millisieverts. Alternatively, to achieve a low dose of radiation exposure, patients can undergo myocardial PET perfusion imaging with rubidium or nitrogen ammonia. These two are associated with a very, very low radiation exposure of 2 to 3 millisieverts. Returning back to the patient, we now have somebody who has persistent symptoms without an obvious diagnosis. So we now go back to the appropriate use criterion and look at follow-up testing, new or worsening symptoms. And you can see here that line 58 or line 63, non-obstructive coronary disease on coronary CTA and an abnormal coronary CT calcium score, both allow stress radionuclide imaging or myocardial perfusion imaging to be carried out as an appropriate indication. She therefore underwent exercise myocardial perfusion imaging. Her stress test findings were as follows. The stress test was terminated due to the end of the protocol. She exercised to a high workload, 12.8 METs, but only achieved 78% of her maximal predicted heart rate. She had a normal blood pressure response. She did not experience chest pain, but she did experience shortness of breath during stress, and her stress EKG was normal. Because she failed to achieve target heart rate of 85% maximal predicted heart rate, the patient was brought off the treadmill, allowed to sit down for a minute, and then was injected with pharmacologic stress agent, regadenoson, to get a more complete myocardial stress. The perfusion findings demonstrated a mildly abnormal test with a less than 10% reversible defect in the territory of the left anterior descending artery. She had a stress ejection fraction of 68% with normal global and regional contractility, and this was felt to be a low-risk scan. In the setting of a low-risk scan, ongoing optimal medical therapy was carried out. I think it's important to review what constitutes a low-risk myocardial perfusion scan. Number one, the ability to exercise is associated with a more favorable prognosis than those patients who cannot exercise and need to undergo pharmacologic stress. Once the patient is able to exercise, functional capacity also predicts low risk. Achieving greater than 10 METs of exercise is associated with low risk. And low-risk treadmill findings, particularly at a workload of greater than 10 METs, is associated with an even lower risk. This includes a normal ST segment response, normal blood pressure response, normal heart rate response. With respect to the perfusion imaging, normal stress perfusion or a small stress perfusion defect, less than 5 to 10% of the myocardium, is associated with low risk. Perfusion abnormalities limited to a single vessel distribution are also associated with low risk. Lack of transient ischemic dilatation is also a low risk finding. Transient ischemic dilatation is demonstrated by a larger left ventricular cavity at stress than at rest. This is caused by marked reduction of subendocardial blood flow during stress and therefore marked reduction of tracer uptake in the subendocardium and an apparent increase in size then of the left ventricular cavity. Preserved ejection fraction post-stress or a normal ejection fraction response when rest and post-stress ejection fraction studies are both carried out are also associated with low risk. I would now like to turn the program over to my internal medicine colleagues from the American College of Physicians to further discuss this case from the perspective of primary care. I thank you for listening.
This is Dr. Gretchen Deemer. I am a general internist in Philadelphia at Thomas Jefferson University. I think this is a very common type of patient that we see in internal medicine, primary care, where there are so many different testing options to start with. Initially, she's asymptomatic, and our global risk assessment calculator puts her at low risk. However, the factors that are not included in the calculator may continue to worry us and her. Using the appropriate use criteria table to select the test ensures that the patient will get one that is useful. Understanding that an abnormal calcium score doesn't automatically require a cardiac imaging test is also important. It would be unlikely to change management as it has a very low probability of showing an abnormality. When she subsequently develops symptoms, albeit atypical symptoms, the table of appropriate use criteria again helps with our test selection. It gives us multiple appropriate tests to choose from to continue to risk stratify her. Using these AUC tools still allows me to tailor my workup based on patient preferences. So for me, the take-home points for the general internist from this case are that asymptomatic patients with low-risk global assessment scores and abnormal calcium scores don't necessarily require further cardiac imaging. When the same patient develops symptoms, the AUC really allows me to tailor the imaging based on individual patient and doesn't take those choices away.